Welcome to PCOM Perspectives, where we discuss news, events, research, and other topics impacting our campuses and communities. Join us as we share our PCOM perspectives. Hello, and thank you for joining us. I'm your host, Dr. Jay Feldstein, and today we're talking with Dr. Robert Cain, President and Chief Executive Officer of the American Association of Colleges of Osteopathic Medicine, otherwise known as AACOM. Dr. Cain is a board-certified pulmonologist who joined AACOM in July of 2019. Prior to this role, he served as the Associate Dean for Clinical Education at the Ohio University Heritage College of Osteopathic Medicine, where he oversaw business development and relationship management for clinical experiences associated with undergraduate and graduate medical education. Over the past 2 decades, Dr. Cain has served on a number of local, state, and national committees to further the advancement of osteopathic medical education. Most recently, he was appointed president of the Federation of Associations of Schools of Health Professions, a forum for representatives of health professions, education institutions to address education's role in organizational patterns of healthcare. And we're really fortunate to have Dr. Cain with us today. I've had the privilege of working with him for the past 6 years, served as a president of the Association of Presidents, and it really is a pleasure to work with Bob, and we really are fortunate and looking forward to today's discussion. And today, Dr. Cain and I will discuss the importance of community-based healthcare, especially in rural communities, and the role artificial intelligence, our friend AI, will play in the future of primary care. Welcome, Dr. Cain.
Well, hello, Dr. Feldstein. Thank you for having me.
And that'll be the last time I call you Dr. Cain. I will affectionately refer to you as Bob, and hopefully you'll refer to me as Jay. So we'll get started. I've got a couple of questions for Bob here. As you've taken on more advocacy roles within the osteopathic medical community, how has your perspective on the DO profession evolved? And what new insights or appreciation have you gained about osteopathic medicine's contributions to the healthcare industry?
Well, I spend a lot of time thinking and talking about the need for our community to understand the value that it brings to the healthcare system. And a few years ago, I started an exercise with different groups within our community, and it goes something like this. If we awaken tomorrow and the osteopathic community no longer exists, what's missing, what would be hard to replace, and who would care? And I think spending time on that is really important to us, that if we're going to drive forward as a strong contributor to the healthcare system in the future, we have to be really clear about what it is we actually bring to that system. The good part is we present a model of education and patient care that's more about what the system is seeking and what patients are seeking. And so making sure that they understand that, because osteopathic medicine, I think, does a great job at balancing humanism and scientific evidence, right? We're trying to make sure our students graduate with that in mind as they practice. The other thing that is important, the OME model naturally emphasizes a primary care mindset. But importantly, that doesn't mean we're training people to only be primary care physicians. I think that's sometimes misunderstood. The schools have that as a strong primary mission in so many cases. But that mindset can be valuable no matter what you decide to do, whatever field you actually enter. And finally, I think the other thing I would add in this space, and we may come back around to it later, is in terms of our contribution, opportunity exists to make ourselves invaluable as a community in a couple of really important spaces. The first is community-based healthcare. And when I say that, I'm trying to specifically talk about non-university hospital-based medical care out in the communities where 80% of healthcare actually happens in the United States. And then importantly with that, a subset of it, which is certainly rural healthcare. Osteopathic medicine was born in rural America and throughout the country still maintains strong ties to rural and underserved parts of the country. And I think that that's a great place of opportunity for us.
So I know it's a hard question. So what are some of the challenges facing community-based healthcare systems today? And how do you think DOs can help solve them?
Community-based health systems, particularly in rural locations, are often financially strapped and facing recruitment challenges. And they're often vulnerable to acquisition and closure. And I think that acquisition element is particularly concerning because our students have for decades, as I was just mentioning, been successfully training in community-based settings. Yes, they train in major academic health centers as well, but even our historic osteopathic hospitals were more in community-based settings. We've been graduating them from our medical schools. They've been completing residencies in those kinds of settings, and frequently then remaining in practice in nearby locations around those and making a difference for those communities. The health systems that are vulnerable are all too often seeking alignment with big name institutions, sometimes for-profit organizations, and oftentimes with that sense of this might save them somehow from the pathway that they happen to be on. But the effect is often not as positive as I think the institutions are looking for. And oftentimes, because those big names don't really have a community mindset, whether it's the mission or the expertise needed to actually operate successfully in that space. Now, the tough part for us, our schools don't have the finances in most cases to create the same relationships as those large university hospitals or to make acquisitions of such institutions, although there are examples of it. But I think there is opportunity for us to get creative. Maybe some goals should be to keep healthcare local and understand and care about those local needs. So, what can we do in that sense? One is to structure the student experience and tell the story. One of the lessons I've learned in this role, and especially as I work with my communications team, is we don't tell our story well enough and loud enough to the people who really need to hear it, and that we can probably do that better at all levels of the profession. The fact that we could try to help make those communities proud of the work that they're doing to teach future doctors. Let them tell the story that we're teaching future physicians to be partners to help build their medical staff and meet recruitment needs and lift up successes in terms of historical retention. How many of these institutions are heavily populated with DO graduates, and making sure that that isn't lost on the people making decisions. And also, a conversation we've been having more of lately is not working with just hospital leadership, but actually working with community leadership to create a triad between the medical school, the hospital, and the community to really create welcoming student environments for our students and hopefully a place where osteopathic medical education can thrive.
Great answer to a difficult question. I do want to give you a follow-up though, and because I think about this all the time, and it really does relate to community-based healthcare because it is and was the backbone of osteopathic medical education for
Yes.
community hospitals, and they're gone. They either died or they, like you said, they were acquired. And in the Philadelphia marketplace, there is only one freestanding community hospital left in a radius of 25 miles, which is insane. That everybody's getting acquired by a larger system or private equity, and they go for profits. And as you stated earlier, but I think that the challenge that I think about all the time, and I know you do too, and it's shared by other presidents, is almost 90% of care is delivered outside of the hospital. Yet we still focus training in the third and fourth year in residencies in the inpatient setting. And I don't know how we make that transition. And I think community-based healthcare is a way to get there. I think, utilizing FQHCs that I know we've talked about and this, our professions talk about and the associations talked about is a way to go. And we should almost own that space because that is basically the definition of community-based healthcare now. So I'm just curious your thoughts on how we transition the experiential learning from a hospital-based mentality to truly a community-based training environment.
Well, one of the things I think you touched on there, and whether you use an 80% figure or a 90% figure, is where's healthcare actually happening? And for most of the last century, the focus of that conversation has been on the large academic health centers, bring people to that large center. But CMS data suggests that only 20% of healthcare is delivered in that setting. And out of 1,000 patients in any given year, one will actually end up receiving care within those settings, right? And most of it, as you're pointing out, even hospitals get a small portion of the care. It's mostly the ambulatory setting where care is being rendered. But where are the dollars flowing, right? And so that's why I think part of our conversation has been with leaders like yourself, with the schools, that we work to develop a highly structured way to communicate that issue to the people who can make a difference, right? So where does that need to go? Well, it needs to head into the state and federal governments, right? And to actually, since they're supporting an awful lot of what occurs, we need to get attention from others who care about the same topic, finding adjacent groups who want to talk about and care about the same thing. And we ourselves have to control and begin to shift where that education occurs. Now, none of that's going to happen fast, right? We're not just going to undo 100 years of funding to
Right.
large centers, and maybe that'll never occur. But what we do have to do is get more directed into that space. And luckily, especially as we talk about rural, like if we plant a stake there and start building out, so many of our schools are located in rural settings, which gives us potential access to and conversations with representatives who can address that. So, what do the communications look like? What does the messaging look like? And develop a plan to move forward. I don't know what happens at the COM level itself, but I think at the national level, we've just finally started talking and thinking that way, and looking at how can AACOM, lead that conversation, hopefully in a successful way, and be persistent and be willing to speak up for others who also haven't been able to get that attention, right? So within that 80%, think about how many voices there are that may have just been waiting for who's going to join us in this conversation. I think that's important.
Oh, well, I say the easiest question for last. So, what role do you see AI and other digital practice partners playing in the future of primary and specialty care? And how can physicians use it to their advantage?
I think this is a simple question with a simple answer. We could spend the entire 20 minutes just on this particular topic. Well, I think a lot of people have concerns about AI and digital partners in the sense that what's the loss going to be? How is it going to take away something instead of how do we turn this into a positive? But that sense of loss we have to accept is very real for many people and those concerns. We certainly want to identify and deal with the negatives, the ethical issues, and the other things that may be of concern, but I tend to be pretty optimistic about this. So let me give you 3 points to sort of answer the question. Let's think about the specialists around us who are too overworked, flooded with consultations, and sometimes consultations that can be relatively simple matters. But with the way the primary care offices are working, it becomes too easy to move that person out. Everybody gets backlogged. And then you get this answer of, well, it's going to be 6 months before you can see this endocrinologist. Being a good primary care physician is really hard, right? I mean, the breadth of diagnoses that can walk into your office on any given day, the knowledge that you need to have, the information about what's changing on all the diagnoses that occur, hard to remain current. And for the patient, patients have challenging lives and don't really want to see an array of physicians. I mean, you don't want your calendar tied up with multiple physician visits. And so what's the opportunity there with AI and technology? So as I listened to the various presentations, I started to take on the opinion that, look, with progressive improvements in technology, a future potentially exists where every physician just has a digital partner, right? That source that is with you all the time. How many times in practice have both of us picked up the phone and called somebody and said, look, this is what I've got, right? But imagine having that right at your fingertips next to you with the use of artificial intelligence as it gets better, that you can use in real time during that actual patient visit. So I see the potential to expand the role of primary care. I mean, think of it as family medicine plus, or general internal medicine plus, or general peds plus. that might actually make those fields more exciting and attractive to students, right? That today we sometimes struggle to get them into those spaces, and hopefully more valuable for patients. That what could I take care of today that I didn't used to because I would have set it off to the specialist. Now, one of the things about this that's fascinating for me, and I'll be interested to hear your response to it, is think about how all this has changed. When I graduated in 1988, if a physician opened a book in front of a patient, they were almost thinking, like, does this doctor need a book to be able to take care of me? But today, if you aren't using a computer, they're actually asking, why aren't you using it? Because they probably did before they came into the office. So I think there are actually exciting times ahead. And as the quote we both heard, AI isn't likely to replace physicians, but it is likely to have an impact on the physicians who aren't using AI. So I think figuring out how to integrate this more fully into our educational process across the continuum and looking forward to that day of having that digital partner is a real positive for healthcare.
No, I agree. And I think well, A, most of the students coming in these days are more familiar with AI than we are. And
Yep.
B, it's a competitive advantage in the marketplace. So if we're graduating young physicians that are skilled in the use of AI, they're going to have a competitive advantage in the marketplace. And I think that's a good thing. And ultimately with better patient outcomes. So, I agree with you. Well, now let's turn the tables time. I'm sure you've got a couple questions for me, so I'll let you have at it.
I do. And I think the good part is they might sort of connect to the things we were just talking about before. So, research shows most clinical training occurs in academic hospitals in large urban areas. What has PCOM done to expand its clinical training opportunities in rural and underserved communities?
Well, we've done a couple of things. One, that's been core to our mission for many, many years, is to really provide care and help build healthy communities in underserved areas, both rural and urban. So in Philadelphia, we've got 3 urban healthcare centers that serve underserved populations. And we continue to send our students and actually bring in other students from other arenas and other medical schools for that experience. And more importantly, is we opened a school in rural Georgia for that reason. In a rural community, as everything that you stated previously, our profession began in rural America, and we opened in Moultrie, Georgia to address the needs of rural Southwest Georgia. We start out with a small class of 59. We're going to try and increase the class size. We started GME in the area with the surrounding hospitals. And we graduated 2 classes, and we've got residents placed in local communities, and hopefully they'll stay. And that's the goal. It's local students, local school, local GME, local practice. And we put our money where our mouth is. We put the capital in, and we're starting to see the returns, and the community is starting to see the beneficial effects of that. So we're going to stay committed to that mission and hopefully open more primary care healthcare centers in urban Atlanta, because we do have a school in Swanee and we need to establish a healthcare center there as well. So we're committed to both rural and urban.
That was one of the exciting things about working with you during those couple of years that you were chair of the Assembly of Presidents was really seeing that commitment out of PCOM and the fact that your placements in those 3 communities give you different kinds of access and the ability to connect and deliver care. And then as well, learning and understanding your feelings about that enhancement of primary care, that role of primary care or concerns about where that could be going. And related to that, that movement of education and training more into the community setting, all things that I think we agree are important. What do you see as the biggest challenges for DOs in 2025? That's an easy question. What can we do as an industry to solve them?
Well, I think the biggest in osteopathic training is clinical experiential learning. We're competing for white coat space with the growth of our own industry, close to, even though it's 40 schools, it's 67 campuses. We've got 2 new schools in Pennsylvania. I think we got 2 new schools in Florida. So we're seeing this explosion in the osteopathic profession, as well as the explosion in physician's assistant programs and nurse practitioner programs, all competing for the same experiential learning space in a consolidating market. As we talked about before, as community hospitals either close or become of large academic teaching centers, and watching allopathic medical schools expand as well, with additional branch campuses and increase in class size. So I hope we can come up with an answer. Now, that may be specific for the Philadelphia marketplace and maybe the Atlanta marketplace. In more rural states where there's less hospitals and less medical schools, maybe that's not a challenge. And maybe we need to go to a national match as an association, much like GME's a national residency match. Maybe we need national matches so that we all share the resource. Otherwise, it's going to become more competitive and more of a commodity and actually increase the cost of undergraduate medical education.
Yeah, it's an idea I've heard from others as well. I mean, the growth is a positive for the visibility of the profession, but other challenges that accompany it, especially around having those quality clinical rotations and a place where, as I think you're aware, we have a working group at AACOM actually trying to look at, do we think about that differently? How do we actually look at that in new ways that can improve clinical education and use the resources that are at hand?
And our student body is so focused on their residency selection. So, which I look at as a shame. When you and I trained at a time where we wanted to go to institutions that didn't have residencies because we got to do more and it was more fun and a great learning experience. Today, most of the students want to go where they have a chance to do GME because there's so much pressure on residency selection. And I think it's unfortunate, but the times have changed.
Yeah, and it's a great point. It does affect the learning, learning for a different purpose. My last question, I think, will give you a chance to talk about PCOM. So you just celebrated your 125th anniversary. Congratulations. What are your hopes for the next 125 years for PCOM?
I think primarily to continue to turn out great osteopathic physicians of the highest quality, whether it's primary care or specialty care, to continue to match so our graduates get the fields they want, as well as to be successful in our other programs, our physician's assistant programs, our mental health programs, PT and pharmacy in the healthcare arena, and to stay true to the mission, to address the healthcare needs, to build healthy communities in underserved urban and rural areas, and hopefully to be around for another 125 years. If you stay true to your mission, I think, and we'll continue to be successful.
Well, obviously the school has a great reputation, has been here for a long time, and I certainly wish you the best that the school does have another 125 years ahead.
Well, I appreciate that, and I think, AACOM is in great hands with your leadership and direction, and looking forward to our continued success working together. So again, I'd just like to thank Dr. Cain for joining us today, and thank you for your commitment to advancing innovation and excellence in osteopathic medical education. I'm Dr. Jay Feldstein, and this has been PCOM Perspectives.